go on smoothly. Welcome all oncology and microbiology at Dr. G.D. Paul Foundation's YMT Dental College and Hospital. I, Dr. Prachi Bhandare, extend a warm welcome to all of you for the CD program Patho Excellence 2022. Tamaso Ma Jyotirgamaya. Light signifies knowledge and abolishes darkness. We now inaugurate the program with the virtual lighting of the lamp. May I now request Dr. Sangeeta Patankar, ma'am, Professor and Head Department of Oral Pathology and Microbiology at YMT Dental College and Hospital, and the organizing chairperson of this event, to give the welcome address, please. Over to you, ma'am.
A very good morning to all of you. Respected Chairman, Dr. G.D. Paul, sir, Director, Dr. Kavita Paul, our Dean, Dr. Meghna Vandekar, Heads of Department of YMT Dental College, Heads of Department of Oral Pathology, and colleagues of various institutes, and my dear students. I welcome you all to this CD program, Patho Excellence, arranged by our department. Now that there seems to be a brief respite from the corona pandemic, we are all very enthusiastic about exchanging knowledge through such scientific activities. After a good response to our previous CD programs, I'm glad to know that so many delegates in and outside Maharashtra have registered for this event. Today, we have in our midst two eminent speakers who are dedicated to research in the field of oral pathology and microbiology. To begin with, I welcome Dr. Meenal Chaudhary, ma'am, Director Professor, School of Oral Oncology at Sharad Pawar Dental College, Samagi, Wardha, who has many feathers in her cap. Not only is she a renowned oral pathologist, but she is also a busy practicing orthodontist. Very few of us know about that. Over the years, she has developed many advanced technologies for research in the Department of Oral Pathology at SPDC. As a true academician, she has delivered many lectures at various conferences and has great number of publications, both national and international, to her credit. Oral cancer is an enigma, and clinicians are still bewildered about the clinical outcome of the disease. There are various factors which are responsible for the survival of oral squamous cell carcinoma patients. So today, Madam will tell us about all the factors which are involved in the post-operative survival of OSCC patients, which is an area so far overlooked. We are looking forward to an enlightening lecture from you, Madam. I also welcome Dr. Supriya Kheur, Professor and Head of Department of Oral Pathology at Dr. D.Y. Patil Dental College and Hospital, Pimpri, Pune. I have known Supriya from her undergraduate days at GDC Mumbai when I was a lecturer over there, and I have seen her growth as a researcher. She is one of the very few oral pathologists in India who does research in clinical settings. She has established regenerative medicine lab at her institute. She is a prolific orator and has received many national and international awards. Today, she will take us on a journey of unusual cases through her slide seminar. I also welcome Dr. Shailesh Shenwa, Professor and Head Department of Orthodontics and Dentofacial Orthopedics at Terna Dental College, who is here on behalf of Maharashtra State Dental Council. Thank you, sir, for accepting our invitation. Though we have organized this CDE program on a virtual platform, we all will surely meet in person in the near future for many such events. Thank you, and I welcome you all once again for this day full of scientific deliberations. Thank you. Over to you, Dr. Prachi.
Thank you, ma'am. Thank you for the kind words. Just a small set of instructions before going ahead. If you have any questions during the presentation, please type them in the chat box. We'll bring them up at the end of the sessions. To keep the quality of the sound functional during the various sessions, kindly mute yourself at all times. We request all the delegates to kindly follow the instructions. We apologize again for all the technical difficulties faced. We are now live on Zoom as well as YouTube. We have over 100 participants joining from Zoom, as well as we have many more on YouTube as well. We are delighted to have delegates joining today, not only from Maharashtra, but from all over India. Thank you all. CDE feedback forms will be shared to you on the WhatsApp chat box, WhatsApp group, as well as chat box at the end of the program. Kindly fill the same. We are delighted to have our observer from Maharashtra State Dental Council, Dr. Shailesh Shenwa, sir. We welcome you, sir, to the program. May I now request Dr. Sheetal Chaudhary, Organizing Secretary of the program, to take over the session, please. Thank you, ma'am. Over to you, ma'am.
Yeah, thank you, Prachi. Very good morning and a warm welcome to all the respected dignitaries, eminent guest speakers, our MSD observer, my seniors, and young oral pathologists and clinicians. Today, I'm feeling overwhelmed and privileged to share this platform here with the most inspiring woman in my life. That is Dr. Meenal Chaudhary, madam, who is my postgraduate guide and my mentor. Dr. Sangeeta Patankar, madam, who's our head of the department, and Dr. Supriya Kheor, madam, who has helped me with my PhD dissertation. We all admire them as they are not only the stalwarts in this field, but are extremely good human beings. With this, let's move towards our first session, which is on factors affecting post-operative survival of patients with oral squamous cell carcinoma. The standard of treatment of oral squamous cell carcinoma is surgical resection with adequate margins. However, many prognostic factors have been found which are known to influence the oncological outcomes in the form of 5-year survival and overall survival. The literature on the factors affecting the survival of oral cancer patients in the West is widely available, but data in the Indian context is sparse. And therefore, it is very important to evaluate and validate the exact causes of poor survival in oral cancer patients in the Indian population. To place research at the clinical decision-making process to have long-term survival of these patients, we have today an eminent speaker, a distinguished and celebrated oral pathologist, Dr. Meenal Chaudhary, madam. Madam, it is our privilege to have you here. Madam completed her master's in orthodontia as well as in oral pathology, which shows her quest for learning. Madam is presently the director professor at the School of Oral Oncology, Sharad Pawar Dental College and Hospital, Datta Meghe Institute of Medical Sciences, Wardha, Maharashtra. Madam has also served as Director Examination, Assessment and Evaluation for the DMIMS University and also as Dean, Faculty of Dentistry. She is an academician and researcher with 25 years of successful experience in teaching, administration, and dental practice. Madam has proved her excellence and success in academia with more than 100 publications in international peer-reviewed journals. Her core area of research are oral cancer and precancer. Madam has been guiding PhD scholars for more than a decade now. She is an excellent teacher and is the winner of the Best Teacher Award at DMIMS for 4 consecutive years. Madam has delivered many orations and lectures at various conferences, CDEs, and workshops, including Dr. A.T. BVG oration at National PG Convention, Kolkata, Dr. H.M. Dholakia oration at the International Oral Pathology Conference 2016, to name a few. On the personal front, I have known Madam for more than 15 years now. Madam provides a new dimension and a wider perspective to any work. Madam has established the department at SPDC Wardha and is one of the pioneers to start advanced research facilities at a dental college. We all have seen her dedication when she organized the National IOMP PG Convention 2008 at Wardha with Professor Reichert as the great guest speaker. At those times, no one could have imagined getting a legend as Professor Reichert to Wardha. All this shows Madam's determination and her vision. She showed us that everything is possible with hard work and dedication. She is not only a teacher, researcher, and administrator par excellence, but a wonderful human being as well. Madam is a perfect example of immense knowledge and humility. With this long list of achievements and glory, I would like to invite upon Dr. Meenal Chowdhury, Madam, and I'm sure that Madam will give us a different perspective to this important topic. Madam, please.
Am I audible, Sheetal?
Yes, ma'am. Yes, ma'am. Perfect.
And am I visible too?
Yes, ma'am. Absolutely.
The screen is full screen. Is it visible to everybody?
Yes, ma'am. It is full screen.
Great. So we are. Thank you so much, Sheetal, for this extremely kind introduction. I don't know if I deserve it or not, but I've definitely been very lucky to have some excellent students with me who have, along with me, been in this journey where I grew as a professional from a lecturer to a professor and now a director professor. At the onset, let me thank Dr. Sangeeta Patankar and the management of IMT College for inviting me to this lecture today. It is indeed, oral squamous cell carcinoma is very dear to my heart, and it is an area which I wish to focus the rest of my professional life on. So I requested Dr. Patankar that this was one area which I wanted to talk about. So, having said that, this lecture is a overall perspective of the post-operative survival of patients with oral squamous cell carcinoma. So it has histopathology in it, but yes, I'm talking more of common sense and what can be done and what needs to be done in the post-operative period of any patient who has undergone surgery for oral squamous cell carcinoma. So with that prologue, I begin. Good morning, everybody. It's a pleasure to talk to all of you. Today, I talk on factors affecting post-operative survival of patients with oral squamous cell carcinoma, an area overlooked. I'm Dr. Meenal Chaudhary. I am from Datta Meghe Institute of Medical Sciences. Bear with me for a minute. Yes. This is my college building. So I bring you greetings from Sharad Pawar Dental College. I hope some of you at least would have visited this college. If you haven't, please give us the pleasure of hosting you anytime you come to this part of the world. To begin, oral squamous cell carcinoma remains the most common malignancy in our part of the world. We account for almost 40% of all malignancies and are the #1 malignancy in central India, especially in our part of the world. And despite numerous interventions and efforts on the part of the government as well as the private sector, there appears to be no headway in this battle against cancer. We seem to be stuck in the same place. Of course, numerous factors play a crucial part in this outcome. That is the widespread abuse of tobacco, the tardiness on the part of the patient in visiting a healthcare professional, the financial implications, etc. And all of these probably contribute to the late reporting of the patient to the primary health centers or to the hospitals. The 5-year survival of oral squamous cell carcinoma has been an extremely painful point for everybody who is associated with oral squamous cell carcinoma. It seems to be stuck at 50% for all the innovative surgeries, for all the innovative ways in which we are attracting patients for early diagnosis. This figure is somehow, it mocks us in the face because we seem to have nothing in store with us to change this particular figure. The 5-year survival of oral squamous cell carcinoma remains static at 50%. And when I say 50%, this is for all stages. Those in T1, fortunate people who are caught in T1 and T2 have a better survival rate. Now, numerous factors play a significant role in this. As I told you, surgery in oral squamous cell carcinoma is far more complex than surgery for, say, a carcinoma of breast or a carcinoma of the uterus or of the ovaries. Firstly, the limitations of late reporting, as I told you. Secondly, the difficulty in obtaining clear margins. I'll talk more about this later. The unique structure of the oral cavity, the proximity to vital structure, which makes tumor removal so much more difficult for the surgeon. And in addition, most surprisingly, most of our OTs are not equipped with frozen microscopy in many centers. And this contributes to making an already difficult task almost impossible. Frozen microscopy is of paramount importance, especially in case of oral squamous. May I request everybody to please. Yeah. So basically, what happens is for the margins which are required in case of oral squamous cell carcinoma, they range from maybe 6 mm to a clear centimeter, ideally a 1 centimeter margin. But what happens is due to the many structures which are in close proximity with the tumors, getting such a clear margin becomes very difficult. Here, the role of frozen microscopy becomes very vital. If a frozen microscopy is available in the OT, a clear margin can be ruled out, or it can be confirmed in the OT itself. Therefore, paucity of frozen microscopy is one of the hidden things which is contributing to the poor survival in patients. tale is not very different in the different parts of the world for oral tumors detected in the later stages. But fortunately, in the developed part of the world, due to the screening processes being more rigorous, the tumors get caught at the earlier stages, and therefore their survival ranges somewhere between 60 to 70%. The perplexing point is that universally headway is being made in reduction in mortality for almost all malignancies, where 5 and 10-year survival has increased significantly. Now, if you look at breast cancer, 5-year survival for breast cancer is now at 90%, 10-year survival is around 75%. 5-year survival for all types of leukemia is 62%. 5-year survival for all stages of nasopharyngeal carcinoma is 62%. But yet, we are stuck at 50%. Therefore, looking at all these statistics, we at Sharad Dental College, which is a constituent unit of the Tamegi Institute of Medical Sciences, we are a tertiary care cancer center and have all necessary facilities for treating OSCC. In spite of routinely assessing margins intraoperatively by frozen microscopy and adhering to follow-up protocols of chemotherapy and radiation, we have not been able to raise a 5-year survival beyond 50%. It effectively means that 1 out of 2 patients dies within 5 years of survival, of surgery. When you look at it in that manner, it really is very depressing. This very disheartening state of affairs made us contemplate hard and look into the causes of death in the post-operative OSCC patients. We also analyzed the role of competing comorbidities in patients who did not survive. For all those who are associated with oral cancer setup, you know that often when you look back at patients who did not survive, the reasons are multiple, and these are the competing comorbidities. I will be talking about it in detail again. Now, the post-operative care in our country seems to be limited to healing in most cases. What do we ask? Whether the patient is healing well, whether that there is no discharge, there is no pus, there is approximations of the surgical defect. Those are the most pertinent questions. The term post-operative rehabilitation does not find much application. There are numerous factors which post-operatively affect the survival and also the quality of life of patient. Now, who can deny this? Yes, there are numerous factors that post-operatively affect the survival. And yes, quality of life again is a concept we are now coming to know that it is very important. These factors need to find a way in our systems so that they become part of our post-operative protocol. Now, this is the area that I want to stress on, that yes, our post-operative protocols need to now get out of the just healing and basic functional rehabilitation of the patient and look at the quality of life of the patients. So what we did was that we carried out a study of 50 OSCC patients who had succumbed post-operatively within 5 years of surgery. We carried out a survey where we talked to the patient's relatives and analyzed the causes of death of the patient. This survey served as an eye-opener and revealed some very unexpected and distressing facts. This survey was very difficult. Getting patients, relatives to talk about a person who is dead, it seems extremely insensitive to the relatives, and convincing them is another task. So when we looked at the causes of death, what did we find? First, patients died of cancer cachexia. Almost 80% of our patients died of cancer cachexia. Continuation of habit resulting in recurrence led to almost 16% of cases dying. Old age. Now, this old age actually is a euphemism for poor physical status of the patient. So that was a large amount, that is 13.6%. The recurrence without continuation of habit led to 13.6% of people dying. Incomplete treatment due to financial constraint. I don't know what was more distressing to us, that these financial constraints led to incomplete treatment, or the fact that we were unable to identify people who fitted into this bracket. These patients simply did not have the means to finish their treatment. These contributed to a sizable 12% of patients. Medically unfit patients who could not undergo post-operative radiation chemotherapy and therefore landed into incomplete treatment were 9%. Cardiopulmonary diseases contributed to almost 7% of all deaths. And then lastly, treatment-related complications caused 7% of deaths. This was the breakup which we saw. So patients with oral cavity cancer face significant risks of mortality from causes other than disease progression. So basically what we found was post-operatively, patients with oral cancer who have been treated by surgery have significant risk of mortality from causes which are related to the disease but not directly a continuation of the disease. These risk factors are the competing causes of death and contribute significantly to the overall survival rate. What it realistically means is that these factors need to be paid heed to and also addressed in a timely manner, so that we can addressing these factors could significantly improve survival. This is the point that needs to be stressed. Yes, people die of malignancy, that is a fact. But when they die, are there some causes post-operatively which can be addressed so that the post-operative survival is better than what it is at present? This is a bar chart of the different causes of death which we found. As I told you, it was cancer, cachexia, continuation of habit, old age, recurrence, lack of finance, unable to undergo radiation and chemo, cardiopulmonary diseases, and treatment-related complications. The first among this, and the most important and most ignored, is the cancer cachexia. It is definitely more widespread and predominant problem seen post-operatively than it was thought originally. It affects 1 in 2 cancer patients. It is not just psychology at play, but there are physical factors involved which result in loss of body mass. Cancer cachexia results in muscle loss with or without fat loss, often to the tune of 20% of the total body loss. Weight. Numerous causative factors are thought to be responsible, like systemic inflammation, negative protein and energy balance, loss of lean body mass, etc. Also, numerous inflammatory cytokines are thought to be implicated in cancer cachexia. And what are they? TNF alpha, the interleukin 6, interferon C, all these are thought to be implicated in cancer cachexia. There are varying modalities which are thought to be effective in counteracting cancer cachexia. Most surprising of them is exercise. Patients who have undergone surgery for malignancy should be encouraged to do some sort of exercise. That is because exercise increases protein synthesis, insulin sensitivity, and suppresses inflammatory response. So basically, all those factors which are leading to cancer cachexia are counteracted. What we must remember is the dietary treatment for cancer cachexia. A patient who has undergone surgery for malignancy or is suffering from any sort of malignancy needs an additional protein intake of zero point 0.7 to 1 gram per kg, which is a substantial amount of protein. Also, there should be an increase of 300 to 400 kilocalories in his diet, of which hopefully 50% is in the form of protein. What has been seen in studies is that this leads to a better quality of life and of course to a better survival also. Other than that, there are drugs which have been in use, like the beta 2 adrenergic agonist, who is a potent muscle growth promoter. Then formoterol, this is a recently introduced drug. It decreases protein degradation, therefore loss of muscle weight. NSAIDs have thought to increase the quality of life and weight gain, but these studies are preliminary in nature. Corticosteroids have shown limited use, but the long-term use of corticosteroids brings with it its own set of problems. There are numerous herbal medicines which are present. There are some Chinese herbal medicine, there are Indian herbal medicines, Japanese herbal medicines, which are thought to be effective in cancer cachexia. Omega-3 fatty acids, again, we know for a fact that they decrease pro-inflammatory cytokines and therefore they are thought to be effective. Thalidomide is one drug which is thought to be effective in cancer cachexia because it decreases TNF-alpha. Most interesting out of of all of these drugs is Ghrelin. What we have seen is that there is increased level of Ghrelin in cancer cachexia. Ghrelin is thought to be a mechanism by which the body fights anorexia associated with cancer. And therefore, oral Ghrelin is now being used and it shows intake of oral Ghrelin shows improvement in lean body mass and total body mass. So this is one very promising drug in the market. Lastly, there is Meges, that is megestrol acetate. These are orally active progesterone containing drugs which lead to increased appetite and increased weight. Now remember, cancer cachexia is often seen in patients and it increases in intensity towards the end of life of the patient. So anything which can stop or decrease the rate of cancer cachexia is beneficial for survival. So all of these drugs can be useful. None of them cause any very serious side effects, so they are definitely worth trying. The next cause of death was the continuation of habit and recurrence. Now, a sizable number of patients are unable to leave tobacco even after undergoing all the trauma of surgery and radiation and chemo. And what happens is when the tobacco abuse is continued, the accumulated tobacco exposure in patient significantly increases. So the patient who after surgery has stopped tobacco and the one who continues with tobacco, in the patient who continues tobacco, the accumulated tobacco exposure is significantly correlating with poor survival and disease-free survival. So what it means is that continuation of habit is a sure shot way of inviting recurrence. Also, what happens is that with continuation of habit, the chances of a second primary increases. As we know, there is already a field in place in the oral cavity. The mucosa which is left behind is already altered in numerous ways and is inherently susceptible to transformation to malignancy. Therefore, continuation of habit increases the chances of a second primary also. Patients often become fatalistic. Now, this is one very strange thing that I've observed. I have patients who have told me that the worst has already happened and nothing worse, more worse can happen. So eating or not eating tobacco now does not make a difference. So they might as well keep eating tobacco. The logic behind this is extremely strange. They, you here patient education becomes very important. You have to tell them that yes, worse things can happen, and you continuing with tobacco, you're not doing yourself any favors. That is a very brutal fact which needs to be told to the patient. But all things said, we must realize that cessation of tobacco is one of the most difficult things to do. All of you know the joke which says that leaving tobacco is so easy. I've done it 100 times. So basically, tobacco cessation takes a toll. It takes immense willpower and a very supportive mechanism for it to happen. Therefore, a support mechanism in the form of a tobacco cessation group, which includes a psychologist, or social worker, or oral pathologist who has been trained in tobacco cessation, becomes of vital importance. What I think is that such support groups should be associated with each oral cancer unit. The function of these groups must be to facilitate tobacco cessation in a patient. This would reduce the overall risk of second primary and recurrence and thereby contribute to better survival. Recurrence is one of the major factors responsible for poor survival, as all of you know. The oral cavity presents its own set of difficulties to a surgeon who is operating on a patient with OSCC. The lack of clear anatomic boundaries, as is in the case of breast, uterus, kidney, etc., makes surgery very difficult. And in the oral cavity, all the structures seamlessly transition from one to the other. That is, the oral cavity will continues into the oropharynx, the soft palate into the nasal mucosa, the maxilla into the base of the skull, and there are no clear-cut demarcating boundaries, this oral cancer surgery becomes very demanding with very little room for error. In addition, field canceration in place, innocuous looking margins which histopathologically may appear to be benign, they are hiding a whole lot of disquiet in them. And here again, I reiterate that many centers do not have the facility for frozen intraoperative reporting, therefore adding to the odds of leaving behind a safe margin. Recent research supports the fact that reporting margins on the basis of histopath alone is incomplete reporting, because molecular analysis has revealed that there are definite molecular changes in the margins which on H&E appear to be normal. So this is one area where my center is working now. We are trying to formulate protocols by which we can look at ISC at the time of frozen microscopy. Hopefully, by the next time we meet, I would be able to give you a protocol where we do not just histopath, routine histopath, but IHC in a frozen setting. That will contribute immensely to give us more knowledge about the margins, and thereby leave where we will be in a better position to leave behind safer margins. Next factor that we found extremely distressing is incomplete treatment due to financial constraints. Most of us come from areas of privilege. We do not realize what poverty is. Unfortunately for us, even though we are fairly empathetic as human beings, we are in no position to know what stark poverty is. As a developing nation, health insurance and accessible healthcare is still limited to a fortunate few. All of us who have worked in new government setups or in trust hospitals will identify with the sheer helplessness poverty brings with it. A cancer victim depletes the financial resources of at least two generations and often If it is a farmer, the treatment cuts into the family's source of livelihood. Often, when I was young and with the arrogance of youth, I used to be full of righteous anger at the delay of patients reporting for with huge malignancies to the hospital. I used to keep asking them why they did not come earlier. But today I understand that often a hospital visit means no earning for those days and often no food in the house. It is so stark and so disturbing. But it's not all hopeless. Things are gradually improving. The government has a number of health schemes which offer financial and medical assistance to cancer patients. The tricky part is making them available to the patients, as often they have to be applied to online and through proper channels, which become a daunting task for a patient who has the minimum of exposure to education as well as the digital world. For benefit of all everybody here, I've listed the government schemes which are run by both central and state government, which are in a position to help patients with cancer. We have the Health Minister Cancer Patient Fund, the Health Minister's discretionary grant, which is also available to patients, the CGHS scheme, which is available for all central government employees, the very important National Health Protection Scheme, that is the Ayushman Bharat scheme, which is really working well. Then the PM's National Relief Fund, it was initially thought it was for emergencies, but it can be utilized for cancer also. The State Illness Assistance Fund, this is a small fund, I think it is 1 to 3 lakhs, but yes, it is also available. The CM's Relief Fund is available, and number 8 is something that all of us in Maharashtra should be very proud of. That is the Mahatma Jyotiba Phule Jan Arogya Yojana scheme by Maharashtra government. I do not know if similar schemes are present in other states. It is remiss of me, I should have found out. This was initially known as the Rajiv Gandhi Yojana. Renaming it has not changed the basic nature. What this is it's a government insurance, medical insurance of some 333 rupees, by which most of the treatment becomes free for the patients. This is a very important scheme. But what the catch here is letting the patients know about such schemes and making them accessible to it. So what we have to do is we have to ensure the proper reach and utility of these funds through patient education and facilitation by way of maybe social worker or just good Samaritans who want to help patients. The other category which we found was, which I've actually 2 or 3 factors which I've clubbed together, is patients who are medically unfit for radiation and chemotherapy, or who had incomplete treatment or old age related health issues. These are kind of interlinked and therefore I've clubbed them together. Now what happens is that there is a distinct subset of patients who develop cancer in the 60s and 70s. Though now with the demographics changing, we have patients who are much early, and now the fourth decade, third decade is often where we see maximum patient. But when malignancies develop in the later ages, the general condition of these patients is such that the body is unable to sustain the insult of chemotherapy and radiation. As one follows the other, that is, there is first chemotherapy, then surgery, or surgery and then chemotherapy and radiation. The patient, often after the cessation of one part of the treatment, is so exhausted and is at the end of his tether, and he just often just gives up. Often the patient is unable to tolerate the pre-surgical neoadjuvant chemotherapy. Now, this is the time where we need to intervene. This is the time when boosting is required. Why? Because incomplete protocols do not yield the expected results and often land the patient in a vicious cycle. He's already taken some treatment, but he's worse than what he was earlier. The benefits which he expected from the treatment have not happened because the patient has taken incomplete treatment. What the patient needs at this stage of life is somebody to support him, somebody to tell him that this is just a part of the journey, this is not the destination. The trick is to just keep going. So morale boosting is extremely necessary here. Another thing which we actually had not thought about, but which our survey brought to our notice, is cardiopulmonary diseases. Now, what happens is tobacco in any form does not just affect the oral cavity, but has far-reaching effects in the other parts of the body. Now, depending in which form it is taken in, whether it is eaten or whether it is chewed or whether it is smoked, the part which is affected, it differs. But generally, the cardiopulmonary system and respiratory system is affected. Often, tobacco is accompanied with alcohol, which further contributes to the damage of the systems. Now, there are numerous etiologic factors which are common to both cancer and cardiopulmonary diseases, such as chronic inflammation and increase in many cytokines. So, what happens is patients with tobacco associated malignancies are also prone to cardiopulmonary diseases, and these, in combination or independently, contribute to the low survival rate. So, the patient who has undergone surgery for OSSC and who is continuing with the habit may die of a cardiopulmonary episode which is not related to the cancer. So, this is one area which we need to actively look into. We have to evaluate the cardiopulmonary status of patients post surgery. Pre surgery, it's already done because the patient has to take clearance, but post surgery, that process has to be kept on. This is a one unfortunate fact of life. Very little can be done with this because treatment related complications are going to happen despite the best of intentions, and a sizable number of patients cannot sustain the rigors of surgery and the post-operative radiation and chemotherapy. These patients generally succumb immediately after surgery or after radiation therapy. This percentage of patients can be reduced by ensuring proper pre-surgical preparation of patient. We need to follow very stringent post-operative protocols, and follow-up of the patient should be ensured so that this percentage of patient is minimized, but often there is very little that can be done. One area which is very neglected is psychology and its role in healing. All of us know that the role of the psyche cannot be overestimated in post-operative healing and survival. A strong and resilient site often leads to faster healing and better survival. This is a fact of life. Cancer patients in India thrust into surgery without any mental preparation. Honestly, how many of us take the time to talk to the patients regarding what is going to happen to him? Generally, a full a patient goes into surgery looking like a human being. He comes out with half of his face either dismantled or looking extremely cobbled together. He has no counseling which has happened to him to prepare him for this. So, what we need to do is pre-operative and post-operative counseling sessions for the patient must be made mandatory so that there is a positive mindset in place which will influence healing. There are numerous studies which highlight the role of counseling in better survival or the role of a positive mindset in better survival. When we talk about the psychology of the patient, one absolutely ignored area is the burden of the caregiver. A major area which is overlooked is the one of the caregiver. In India, institutionalization of cancer patients is still in its infancy. With the oral squamous cell carcinoma being patients being predominantly male, the major burden of caregiving falls either on the wife or the mother. God forbid, if the patient is a female, she is mostly left to her own devices. It's a very lucky female who has a son or a husband are looking after her. We must remember that post-operative care in case of OSCC is not a matter of days or weeks, but it is a long time prospect. And caregiver fatigue or compassion fatigue or caregiver burnout, whatever you want to call it, occurs when the caregiver has been at this task for months on end and feels physically, emotionally, and psychologically exhausted, often leading to a change in attitude towards the patient. After a period of time, compassion fatigue becomes inevitable, and this directly affects both the caregiver and the patient. There are self-help tools designed to address caregiver fatigue and to ensure their well-being. Most of us are not aware of this. We at DMMS have recently started looking at them, and we have found them to be very effective. So at DMMS, we are looking into the effectivity of the global mental health assessment tool, which is known as the GM-HAT. And what we have done is the GM-HAT is in English. Now we have translating it in the way into various local languages and putting them piloting them on patients. And at the piloting level, they are proving to be very effective in counteracting compassion fatigue as well as dealing with quality of life. But this data is still primitive. We have not gone into studies which are multicentric in nature, so it is in process. Another tool which we found was effective was the Warwick-Edinburgh Mental Well-Being Scale. Now, again, what happens is that psychological disorders and mental well-being are negatively correlated to each other. An increase in psychological disorders means poor mental well-being, and hence these two scales together give a complete evaluation of both the patient and caregiver. One very good thing about the GM-HAT is there is a version of GM-HAT which can be self-administered. So basically, you don't need professional people to do it for you or trained manpower to conduct this particular test. The test can be done on yourself, and it tells you the mental status of the patient. If on the scale a particular figure comes, then it says that you need to go to a mental health worker. So taking all of these factors in account, the need of the hour is modification in post-operative protocols. Today, most of the post-operative protocols are limited to monitoring of healing, administration of radiotherapy wherever necessary, and addressing the surgical defect in the most basic of fashion. The need is to modify this post-operative protocol so as to address those factors which are post-operatively affecting survival of the patient, such as the dietary needs of the patient, the need to look into the patient's mental well-being, to include speech therapy so that the patient can communicate adequately, and also actively monitor his cardiovascular status. An additional parameter that needs emphasis is to look into the cessation of habit so as to prevent further damage to the residual mucosa. So, how do you do all this? Firstly, there is this concept of support team. Taking all the post-operative needs of the patient into account, each oral oncology unit needs a support team in place. The team should comprise of nursing staff, social worker, psychologist, speech therapist, dietitian, and each member will have a targeted responsibility whereby they will facilitate the recovery process. How and what each person will do, I will be coming to that. Coming out through coming to this particular point is extremely important, because now we know that the post-operative protocols need to be modified. Now, how do we modify them? By empathetic follow-up. At present, we are just doing follow-up. What we need to do is do an empathetic follow-up. Now, what is the importance of empathetic follow-up? The importance of follow-up is was not lost on any of us. We realize it's a very important part of any study. We realize that any data to be of relevance, its association with either progression of disease or survival is prime. However, our follow-up is generally through an impersonal voice on the phone and limited to the patient's disease-free survival. We also know that there are numerous other factors which now know that numerous other factors which affect the patient's survival, and they also need to be evaluated periodically. A few personal questions inquiring about the physical and mental status of the patient go a long way in building a rapport with the patient and also facilitates timely interventions wherever needed. Our follow-up question is need some work and some attention to their content. So what I suggest is the checklist approach to follow. Ideally, follow-up should be of two types. One, the monthly telephonic follow-up, and two, the 6-monthly hospital-based follow-up. The two types of follow-ups address distinct areas of concern, as the questions will reveal. Monthly follow-up typically will be conducted over the phone and will have a series of questions like, is the wound healing properly? Is there any pain or discharge? Can the patient eat? Is there any loss of weight? These two questions are addressed towards concerns of cancer cachexia. Has the patient started working? Again, his integration into society and the psych at work. Is the patient sad and unhappy? Again, psychological aspect of the patient. Important, has the patient stopped tobacco consumption? Whether the habit has been stopped, whether it is still in process. Has the patient stopped drinking alcohol? Again, in line with the tobacco consumption. And does the patient have difficulty in carrying out everyday tasks? This question is addressed towards evaluation of cardiopulmonary system at a very, very gross level, of course. When the patient comes for 6-monthly follow-up to the hospital, then again, then this is a standard thing which we do in the hospital. That is, we examine the patient, look at the wound. If there any revision in treatment protocols is required, we do that. Imaging wherever necessary, and prosthetic and aesthetic planning. If it has already been done, then whether it is adequate. If it has been done in a phase-wise manner, then the next phase of the planning. And if it has not been done, then the planning for both of them. And also evaluation of general health, especially the cardiovascular systems, as well as the general overall health of the patient. One thing which we can do in India and which has not been done as yet, which is fairly common in other countries, is concept of support groups. Now, with the widespread use of WhatsApp and other such apps, forming support groups is really a boon. Support groups are typically free, they are anonymous, and they are patient or survivor discussion forums which are open to public, where those currently fighting oral cancer and their families can gain insights and inspiration from those who have not been there before them. These support groups can be initiated by the local cancer hospitals and then handed over to the members for administration. Since nowadays digital spread of information can also be done in local languages, its utilization will be really widespread. Such groups not only will provide information and support, but also emotionally make the patient aware that he is not alone in his suffering and there are other people like him who have gone through the process and who have come out successful. As I told you, the best part of any treatment, the best way to uh, stop a disease is to prevent it, especially in the prevention of 95% or maybe more of OSS is so simple. What is it? Stop tobacco. In my so many years of clinical practice, the number of malignancies of the gingivobuccal sulcus which are not associated with tobacco, I can count on the fingers of my one hand. So basically, the prevention is very simple: stop tobacco. The solution is right in front of our nose, but it might as well be on the moon. We are left helpless in the face of the mighty tobacco. Public policies, government efforts, professional efforts galore have yielded nothing. The number of cases keep going up and the burden on our health infrastructure keeps mounting, and nothing we do seem to make a difference. The need is to discover new innovative methods to stop this menace. I realize tobacco cessation is very difficult, just as we know that there is a set of genes which predispose a person towards alcoholism. Maybe the same is true for tobacco use. This is one school of one area, food for thought I leave behind for all of you. Maybe there is a set of genes which make a person more susceptible towards tobacco addiction. Why? Because we see families which indulge in tobacco and across generation. In the same family, you might find the grandfather, the father, and the son, all of them abusing tobacco. And tragically, a father suffering from OSCC does not discourage the son from using tobacco. Maybe we can use the patient's stories to spread the message to stop tobacco. Tata has already made an effort. Before every movie or in the interval, we see these extremely disturbing images of OSSC patients who tell their story of how they abused tobacco and where it landed them. I sometimes think that if those pictures and those videos cannot stop a patient from tobacco, what really would? So, what is the hope from the new age generation? Me and my generation of oral pathologists have tried a bit. We held camps, we celebrated days, we tried to convince people to stop using tobacco, but without much avail. For that, we owe this new generation an apology. Our efforts have not been enough. But we have great hopes from this new, smart, technically savvy, well connected new generation. May you succeed where we failed. May you have more effective tobacco crusaders, and may you see better survival rates in oral squamous cell patients and also fewer cases of OSSC. Please God. This slide I have put on the request of an oral surgeon friend or colleague of mine. He told me, ma'am, if you're speaking to a PATH conference, please, these are a few things which you say from my side. He said that histopath reporting on receiving the resected specimen and the resected nodes, the histopath report should address the following things. I know I'm probably repeating everything, but again, let's just go through whether we are missing anything while reporting. First, go to the advancing front. In a resected tumor, it is very, very important that you go to the advancing front and grade that advancing front. Why? Because the grade of the advancing front is a grade of the disease, and that is what is going to tell you the prognosis of the patient. A poorly differentiated carcinoma, irrespective of the stage, is going to metastasize and lead to poor survival. So always grade the advancing front. Look for lymphatic and vascular invasions. If you find them, please make it a point that you tell the surgeon. Perineural spread, very important. Look for it. And if you do see it, put it in your report. If the nodes are sent to you, nodal metastasis, if it is present, and what type, where is it located? Is it inside the node? Is it between the node and the capsule? Is it outside the capsule? All these things matter and they may have a huge impact on the survival of the patient. What kind of inflammatory response do you see? Whether there is adequate, good, not enough, and whether it is eosinophils, mast cell. It tells you how the body is reacting to the tumor. And lastly, the status of the margins. If you cannot rule out a margin in the frozen, look at it again and again at the histopath. Look at it molecularly at your level, when you have sufficient time, when the specimen is out, and give a complete report to the surgeon, so that together he takes the decision of whether chemotherapy is required, how often the patient has to come for follow-up, what are the things he needs to look into, whether there is any radiation which is required, whether he needs any other type of immune therapy. All that will come from your report. So this talk, what is the take-home message? First, we need to focus more on the post-operative follow-up period. We are ignoring the post-operative follow-up period, or we are taking it very lightly. The causes of poor survival include factors other than recurrence, which need to be looked into. These factors contribute substantially to the poor survival of patients. Many of these factors can be intercepted in a manner so as to minimize the damage. Management of these factors will definitely help in better survival rates. And there has to be an emphasis on the psychological, medical, dietary support to the patient, and this cannot be overemphasized. All of this, even if it raises the survival rate by 5%, 10%, it is definitely worth doing. With that, I thank all of you for your very, very patient hearing. I thank the YMT management, Dr. Sangeeta Patilkar and her team, and especially Dr. Sheetal, for inviting me to this talk. I hope it has not been very long-winded. Thank you so much.
Thank you, madam. It was a great speech.
Thank you, ma'am. Thank you for all your valuable insights, sharing all the valuable insights on the overlooked area. I'm sure a survey like yours done in different cancer centers all over India can be of great help in determining the factors that affect the post-op survival in OSCC patients, ma'am. It looks like we have some questions in the chat box. Ma'am, if you would please help us with the questions, please. And the first question is, which are the common short-term and long-term complications in post-op OSCC patients? Which are the common short-term and long-term complications in post-op OSCC patients?
That's a very nice question. The most common complications, I have already charted them out for you. All of these are post-surgery complications. So can you repeat the question again? How important is?
Question is, which are the common short-term and long-term complications in post-op OSCC patients?
The common immediate post-surgical complication is aspiration poor, and there is the cardiopulmonary issues, or just the patient system not being able to survive the onslaught of surgery, that is, and patient dying with that. That is one of the most common immediate complication. Long-term complications I've already enumerated. Most of them are, the cancer cachexia, there is recurrence, there is cardiopulmonary rehabilitation, and one often overlooked area is the patient just giving up on surgery. Does that answer your question?
Thank you, ma'am. I hope that answers the question. Ma'am, the next question is, how important is interdisciplinary approach in managing post-operative factors in OSCC patients, and what is the best interdisciplinary approach?
Interdisciplinary approach is, of course, very, very important in managing post-operative factors in OSCC patient, because it is no longer the domain, remains in the domain of the oral surgeon or the dentist. We need nursing care, we need psychological treatment, we need a dietitian in place. So it is an extremely multi-disciplinary approach which is needed. The best interdisciplinary approach, as I told you, is the team approach, where you have people with targeted responsibilities. So there would be a psychologist who would, and fortunately for us, what COVID has taught us is that it's not always necessary to physically go out in the field or physically talk to the patient. So a psychologist who could assess the patient's psyche, a dietitian who could give tips about the protein intake of the patient, how to increase it, a speech therapist who could tell exercises to improve the speech of the patient. So basically, a combined team approach is the best interdisciplinary approach. The next question.
Yes, ma'am. The next question is regarding COVID-19, as you mentioned just now. Ma'am, can you please clarify how does COVID-19 modify the factors affecting post-op survival in OSCC patients?
It's too early to tell you what exactly is happened because of the COVID and how it has modified the factors affecting post-operative survival. But one thing which I can tell you is many surgeries got delayed because of COVID. And those which were initially T1, T2 probably are now in T3, T4. So we are looking at a epidemic of T3, T4 tumors, which maybe initially were in better stages, now will come to us with huge tumors. That is one thing. Secondly, with COVID, there has now been in everybody's mind a fear psychosis of going to the hospital. So that needs to be overcome. And the long-term effects of COVID, now especially those where we saw huge amounts of mucormycosis, what is going to happen to them, and whether we will be able to see any different subset of patients who had suffered from COVID and simultaneously are suffering from OSCC. That is something for the future. It's a good place to do research here, something we can think of.
I once again announce, if you have any questions to ask ma'am, please put them in the chat box. It looks like we have covered all the questions. Thank you, ma'am. Thank you once again. We are delighted to have you as a guest speaker today. It was great to hear you and meet you virtually. We hope to meet you in person soon.
Thank you so much, Sangeeta. It's a pleasure. The pleasure is all mine.
Thank you, ma'am.
I must thank Dr. Meenal Chaudhary, ma'am. It was a really, really interesting and informative lecture, and I'm sure not only the oral pathologists, but also the oral medicine people and the surgeons also who are probably attending this, it was of great help to them. And it was definitely a topic which was not too much looked into by the pathologists. And I think pathologists are also ultimately clinicians. So we should take care of the post-operative factors affecting the survival of that patient. So, madam, it was really nice of you to talk on this different kind of a topic. And I thank you once again for attending.
Thank you, ma'am. Thank you for your kind words. We thank Dr. Meenal Chaudhary, ma'am, once again for this valuable and insightful knowledge sharing session. We now move on to the next session for today. Take a quick 2-minute break to just get the technical aspect in place. We are doing a trial run. So kindly bear with us. I request Dr. Supriya Keur ma'am to kindly share the screen to do a trial run. We request Dr. Meenal Chaudhary ma'am just to go back. Dr. Meenal Chaudhary ma'am, we have a question for you ma'am. I request Dr. Meenal Chaudhary ma'am to come online, please. We have a quick question for ma'am while we do the trial run for the next presentation. We will surely take up this recent question up to ma'am and come back with an explanation and an answer for the same shortly.
Can you see this screen?
Hello, Supriya ma'am, we can hear you.
Yeah, Dr. Prachi, can you see the screen as well? No problem.
Yes, ma'am, the screen is visible. If you could just run the slideshow once, we can check if it is running on full screen.
Is running?
Not yet, ma'am.
Can you see?
And we can see the slide, but not the slideshow.
Now?
Not yet, ma'am.
So you can see the first slide, that's it?
And we can see a histopathological slide.
Supriya, can you hear me?
Yes, ma'am. Yes, ma'am.
Supriya, I think you should go full screen. Then only they can see it actually. You should go for full screen. This is just your PPT has.
Ma'am, I actually went full screen. Option.
Ma'am, if you could press F5 once and check if we can go full screen.
You see now?
Yeah. Yeah, it's come now.
Yes, ma'am, done. Thank you so much. Thank you.
All the best, Supriya. Good day.
Thank you, ma'am.
Thank you. Thank you for the support, ma'am. Thank Radhika, ma'am, to thank her for the support. Ma'am, if you could exit the screen share.
Yeah,
Thank you.
I'm sorry, I was disconnected. Is there any other question?
Yes, ma'am. Thank you for joining back. Thank you so much. I will quickly take a small question before we move on to the second session for the day. The question for you, Meenal ma'am, is, ma'am, could you enlighten the post-survival factors in arecanut-induced oral cancers? Would you enlighten the post-survival factors in arecanut-induced oral cancers?
The survival factors for OSCC, irrespective of whether it is tobacco or areca, don't seem to be very different. Yes, but a study where we have taken only OSMF, OSSCs and looked into the survival of that subset of patients, and just tobacco OSSCs and survival of that subset of patients probably would lead us to to the factors which differ in these two. As of now, according to me, they should not differ too much. They should be the same. That is, whether there is a recurrence, whether there's a second primary, whether there is regional metastasis, what is the general condition of the patient, whether there is cancer, cachexia. So I think
Sorry, we seem to have gotten disconnected from Meenal ma'am. As ma'am had suggested in her answer, there is no rather factors that affect irrespective of the habit of the patient in the post-survival as a post-survival
and that
factors.
is what I think is the scenario. But yes, I have not as yet analyzed it group wise. I mean, a subset of only OSMF with OSOC and OSSC, which is tobacco associated. Because generally what happens is the OSSC group also has not just Erica, but there is some amount of tobacco associated in that group also.
Thank you, ma'am. Thank you for the answer. As I had said before, a survey like yours, ma'am, should be carried out all over India at various cancer centers to search for the post-survival factors affecting the post-survival prognosis in OSCC patients in different areas.
Definitely, Sangeeta,
Locations.
if we could coordinate and do something like that. That, and the second thing which I'm really very invested is in formation of support groups. So maybe we could, 5 or 6, at least 5 or 6 or more centers which have a common goal and a cancer hospital, we could think of doing something in common.
Thank you, ma'am. We look forward to collaborating with you and all over India. Thank you for your valuable input and answering the question.
Thank you. Thank you.
Thank you, ma'am. We now enter the next session for today. I hand over the session to Dr. Sheetal Chaudhary, ma'am. Over to you, ma'am.
Yeah, thank you, Prachi. After getting a different perspective to post-operative survival and post-op rehabilitation regarding oral cancer patients, we now move on to our core area, and that is histopathology. It is said that there is no art more difficult to acquire than the art of observation. As pathologists, we are all aware of the complexities, mysteries, and diagnostic dilemmas associated with oral lesions. A good pathologist must have good observational skills, attention to detail, and a talent for pattern recognition. To make us understand the complexities and intricacies of oral lesions, we have today a very dynamic speaker, Dr. Supriya Kheur.
You'll have to unmute this.
Dr. Supriya Kheur ma'am is a young, vibrant orator with a teaching experience of 18 years. She did her BDS in 2000 from GDC Mumbai, MDS from GDC Nagpur in the year 2003, and PhD from Dr. D.Y. Patil Vidyapith, Pune. Madam is presently working as professor and head of the Department of Oral Pathology and Microbiology at Dr. D.Y. Patil Dental College and Hospital, Pimpri, Pune. Madam is also in charge of Regenerative Medicine Laboratory at Dr. D.Y. Patil. Madam has been guiding PhD scholars since 2018. Madam has received many rewards for paper and oral presentations in various conferences. She is a recipient of many prestigious awards, including Lord Vermont Award in 2009, Best Female Dentist in 2018, Outstanding Social Contribution Award from Rotary International. Madam has been the recipient of various research grants. She is also a recipient of a research fellowship from the Indian Academy of Sciences, Bangalore. Madam is also actively involved in various college committees and university positions like Chairman of Preclinical Board of Studies, Member Secretary Scientific Committee, Member of Board of Academics. Today, Madam, with her immense knowledge, will help us to become better diagnosticians by demystifying the oral lesions. Madam will address us on histopathological insights into oral lesions. Madam, over to you. Thank you.
Thank you so much, Sheath, for a very warm and kind introduction. Am I audible? Is the screen seen?
Yes, ma'am.
So we started the session with a very nice and a different talk by Dr. Meenal ma'am. And it is imperative that now we realize that post-operative care should also become a part of cancer patient, right from diagnosis, treatment, and post-operative care. So today, moving on with your CDE program, I take this opportunity to thank YMP management, Department of Oral Pathology and Microbiology, and Dr. Sangeeta Patankar madam, who is actually my teacher. She was my teacher in 3rd year, and she is responsible for inculcating a very systematic and methodical approach towards the subject. Thank you so much, ma'am. And I hope I can share and discuss with you a few of the slides that we received. So the topic goes as histopathological insights into oral lesions. And we have started only with the thing that we should do more than we intend upon ourselves to do. So the need of the hour is to look beyond glass slides. Once if we start that saying that oral pathology is more than just seeing the glass slides and diagnosing the lesion, that we set upon ourselves into a more futuristic, more progressive state of our subject. So when I am discussing today about the cases, I would be looking at the clinico-pathological correlation of some oral lesions. So many times when we look at the slides, we just look at the slide, not at the patient. And today we have looked at another approach that we have to look beyond treatment and beyond diagnosis also. So today we'll be discussing 6 cases where the clinical presentation was different, though the histopathology was not a very enigmatic picture. So, and also we will be discussing the histopathological analysis of stroma in oral squamous cell carcinoma. Just in continuation with ma'am's lecture of what a surgeon or what a treatment specialist expects from us when we diagnose the lesion, and how do we actually take care of many features which are seen in the stroma in OSCC, which we either neglect or we are not aware of. So going with it, let us see few cases where the clinical correlation and the histopathological correlation was something different, not what is routinely seen in our practice. So the first case was of a 2-year-old male child. He was referred to our department in March 2020. He had a swelling intraorally concerning the anterior mandible. It looks actually in the anterior area, but it was more towards the right side. It was approximately 5 into 6 centimeter in dimension, and the mass was present since birth. That is what the history the mother gave us. But it was slow growing, and the patient was completely asymptomatic. There is no pain involved at all, and was firm on palpation. CT scan of the patient was seen, and it revealed the lesion extending from the right side to the canine of the left side. You can see the CT scan of the lesion, and the developing tooth buds are also there. This looks like a proper solid lesion. It didn't have any cystic component, and it also showed an enlargement of the lower border of the mandible as well as the buccal and the lingual plates. So a incisional biopsy was performed for this under GA, and the biopsy specimen was actually given to a general pathologist, and he diagnosed the case as ameloblastoma. We can see why he did that. There was odontogenic epithelial islands where strands were seen with tall columnar cells at the periphery, and few areas of stellate reticulum-like cells were seen. Somehow there was an area where you could see pale eosinophilic structure which looked like inductive changes, and the stroma was also different from what we see in ameloblastoma, but ameloblastoma diagnosis was given for this patient. But the patient couldn't actively come for treatment for good 1 year. So the patient reported back to us in August 2021. So a fresh CT scan of the patient was taken, which showed the lesion was roughly the same as what was seen in 2020. And as per ameloblastoma diagnosis, resection of the whole mandible was done, and PMC flap was given as a part of rehabilitation. So this was the grossing that we received. In your C, D, E were present on the right side, and this is D, and E is submerged, and we still have a developing tooth follicle. What does it look like in grossing? The whole area was very well encapsulated, and it showed hemorrhagic areas. That is all. The buccal plate was extended or expanded much more than the lingual plate, and the inferior border was also involved. When we started taking the sections under microscopic examination, this was the first slide we saw. The majority of the lesion was like this. You had, and we already had the diagnosis of ameloblastoma. So you had tall columnar cells at the periphery. The odontogenic epithelium was proliferating in form of cords. You had few cystic areas that were seen in the stroma. But just look at the stroma. It resembled more like dental papilla. Primitive ectomesenchymal cells with plumb proliferating fibroblasts. So our first impression was probably it is ameloblastic fibroma. Further going into the section serial cuts, we saw these kind of pinched out odontogenic epithelium with an end bulb appearance that you see over here. Plus, we also had certain hyalinization which was seen in the subepithelial area. The stroma was plumb proliferating fibroblast, ectomesenchymal cell-like with few blood vessels. This was the main picture that we saw. Few follicles were also seen. There was cystic degeneration seen within the follicles in few areas, probably because the span was over 2 years, 2.5 years in the patient's mouth. Tall columnar cells undergoing some squamous metaplasia, stellate reticulum-like cells. And then we saw these kind of inductive changes within the mass. Can you see pale eosinophilic areas were seen? This was odontogenic epithelial which showing cystic degeneration. So few areas showed hyalinization or inductive changes, but there was larger inductive changes more in accordance with pre-enamel-like or pre-dentine-like matrix. We saw white spaces over here, and the stroma was consistent with ameloblastic fibroma, primitive ectomesenchymal cells with plumb proliferating fibroblasts. For the higher section revealed this pale eosinophilic area. At first go, I thought it was more like osteodentine or dentinoid-like. But we didn't get any typical features. Most of this was like this. And when we came with further closer section, we saw this segment. This is very typical of dentinal tubules that you see. So there was dentine deposition in this tumor with odontogenic epithelial lining seen and the ectomesenchyme descending ameloblastic fibroma. So we gave this was another section that was seen which showed the oral epithelium which is going in the form of bud stage. And this was probably true because of the age of the patient. And serial sections we kept doing till we were initially thinking we'll keep it as a museum specimen, but we kept removing more and more slices to check if we get any other hard mineralized structure like enamel or we get cementum, or is there any way we could get some odontome-like features, but we didn't get anything. Most of them were showing, some areas were showing dentinoid-like, and most of them were odontogenic epithelium with ectomesenchyme-like stroma. So the final diagnosis of ameloblastic fibrodentinoma was given. This is actually my first case diagnosed as Aminoplastic fibroadentinoma, and I was super excited looking at the patient and the size of the lesion. So it could be because of COVID that the patient couldn't report back and it slowly increased in size, but it was really massive. And as the initial diagnosis of ameloblastoma was given by the general pathologist, they had resected the whole of the mandible. But the lesion was involving most of the areas, barring the posterior area and the ramus. So when you talk about ameloplastic fibroadentinoma, the prognosis is similar, or the biological behavior is similar to ameloplastic fibroma. But in cases of dentinoma, there is an inductive change, or there is an extra deposition of tooth-like structure. So it remained more differentiated form of the tumor. So when we are taught in third year and all, we were taught about this continuum theory that you have ameloplastic fibroma, fibrodentinoma, fibrodontoma, and then odontoma, which was given by Khan and Pan. But now this theory is no longer regarded, and you can have any of these tumors arising de novo. Looking at the second case, we had this patient who reported to us last year. He's an 18-year-old male patient. He had a swelling in the pre-auricular area, the parotid area, since past 5 years. So he had got a surgical excision done 4 years back, but the lesion recurs back again after 4 years. So since 6 months, the lesion was growing, and this is the present size. On clinical examination, we didn't get any facial nerve dysfunction. Now, we did this to evaluate if there was any malignancy, and looking at the area, we thought most commonly it is salivary gland malignancy. So we thought that we will do USG, we'll do MRI in that area. So USG guided FNSC gave an impression of pleomorphic adenoma. Patient didn't have the report of what had been the surgical excision or surgical diagnosis 4 years back. He said he had lost it. So we thought it is probably pleomorphic adenoma considering the location, and the USG guided FNSC also gave the similar impression. This was a CT that was done, and you can see that you have the lesion which is present over here, completely involving the parotid gland. On microscopic examination, we got a large tumor which was very cellular. It was encapsulated partly in one section, and in one section completely encapsulated, completely cellular. Like, you don't get any epithelial component over here, just connective tissue, stroma, not many blood vessels, fibroblasts. Look at this. This is another section which showed encapsulation. The tumor was not invading into the capsule at all. It was well circumscribed, and the whole of the tumor showed these kind of cells. I'm sure most of you have guessed, but what I want to say is, if you look at it, you see completely cellular stroma and some peculiar arrangement of the nuclei. And the whole tumor looked isomorphic, like there aren't too many areas which differ in histological appearance. This was another section that was taken. It goes in continuation with those kind of palisading nuclei that we see. And then there was collagen fiber deposition, some areas of myxoid stroma, and some fibroblastic areas. And again, there were some areas which were a little loosely arranged and some areas which were densely packed. Yes, it was Antony type A and type B. So we are talking about schwannoma or neurilemomas. So you could see over here how the palisaded appearances. I will show a higher magnification photograph as well. So can you see over here? And then there was an area which was loosely arranged, not many of it. So this R tumor showed maximum compactly arranged Verroque bodies or Schwann cells, which were arranged in a typical location. So what I want to say is, this is a photograph of a normal nerve cell, how it appears like when you take a cross section. So you have the cell, the nuclei which were arranged, and the connective and the cytoplasmic component. So when they get arranged into this palisaded appearance within a nuclear zone, we call it Verroque body, which is the diagnostic feature of Antony type A type of areas in schwannoma or neurilemoma. So this was very classically seen. So there were few areas of large areas of hemorrhage were present. We didn't get too many Antony type B. Mostly it was Antony type A's. The higher magnification. the palisading of the nuclei, areas of hemorrhage. Again, over here, very classically, so these are Verrucay bodies, and we decided we will be giving schwannoma or neurolemoma as a diagnostic feature till we got areas which shows these kind of myxoid appearance. These are not antennae type B areas. These are just areas which shows degenerative changes. Large areas of hemorrhage, blood vessels, extravasation of RBCs, and these kind of degenerating areas seen all around. The higher magnification, you can see the stroma, see the myxoid changes in it, and then these areas of hemorrhage. The whole lesion was excised and we gave a diagnosis of ancient schwannoma, which is a type of schwannoma that is very commonly seen in oral and maxillofacial areas. And this was a picture which shows that the facial nerve was spared. So intraparotid schwannomas are a rarity, and especially if it is incorporating within the, originating from the facial nerve and involving the whole of parotid, it only like 1% of the schwannomas occurring in head and neck areas are these. But it has good prognosis. So the final diagnosis given was of ancient schwannoma. Continuing with the same phase where you see a mass which is predominantly in the area of salivary gland and mostly would have had salivary gland diagnosis, we had another case of a very young individual, 17-year-old patient who had a lesion since past 1 year. Now, most of my cases, there was a delay in diagnosis because the patient didn't report back because of the COVID situation. So the clinical impression was of pyogenic granuloma. There was no significant self-history or family history, medical history. There was no history of COVID, nothing. It's just a small lesion which has gradually increased in size, which was asymptomatic, involving 2.6 to 2.8 in the maxillary area. So we thought it is pyogenic granuloma. There was no bleeding around it. There was no stalk. So it was completely sessile. It was not pedunculated, but no surface ulceration. No, patient was completely asymptomatic. So we excised the whole lesion. See, this is how the lesion, they excised the tooth as well, because it was third molar and second molar that they excised. And you can see the gross specimen. It seemed completely encapsulated. So we were actually arguing with the surgeons that why have you excised the teeth? But they were like, it is going beyond the root. So we excised the teeth as well. And it showed a white glistening surface. This is something that you should look out for when you are doing the grossing, because sometimes if you see hemorrhagic areas or if you see pyogenic granulomas, they're generally pretty soft in consistency, and you can feel that it probably had hemorrhagic component, whereas this surface showed glistening white areas and it was soft to firm in consistency. When we did the microscopic analysis, the overlying epithelium was seen, which was slightly proliferative, hyperparakeratotic epithelium, and you had a Ghrelin zone where there was no lesion seen. And towards the area, towards the deeper aspect of the lesion, we saw a large cellular tissue. You see over here, highly cellular tissue where you see these proliferation of fibroblasts or spindle-shaped cells. Like in cases of schwannoma, we could just see the palisading appearance of the nuclei. But here we can make out the shape of the cells, which is little spindle-shaped and compactly, densely arranged. Like this. We have the cells which are growing like this, and there are some areas interspersed between these vesicles which showed a different presentation. And this was the picture homogeneously throughout the section. There were not too many changes in it. The collagen here appears different, it seems branched. And this was the picture, higher magnification of this. So you see the cells which are very prominent, very specific type of nuclei which are blunt in one end, and there are these other type of cells which are seen. And these nuclei have a slight bend, so which is also known as diving dolphin type of nuclei according to some pathologists, where you have a slight bend that is seen towards one end. So this was neural tumor, or we were looking at, or neurofibromas, which has a slightly bent nuclei and more serpentine kind of nuclei, which is taught to us generally during our pathology postings. See this? Whereas this was a cut section of the nerve where you had few other different kind of cells, you had blood vessels, and you had a lot of fibroblasts that were proliferating. A diagnosis of neurofibroma was given for this. Another aspect, see there are some myxoid changes we can see over here. Now neurofibromas can show you myxoid changes, can show you a lot of mast cells, blood vessels, fibroblasts, and the collagen which appears slightly different, which is also known as shredded carrot collagen. And the cells are not uniformly present. Same type of cells are not. So you see different type of nuclei, different types of cells over there. This large area of hemorrhage and some degeneration was also seen. But the duration of the lesion was only for 1 year. And there was no other lesion seen throughout the body. We did S100, which stained the Schwann cells sporadically. It is not present generalized. And we gave final diagnosis of neurofibroma. So I want to take 1 minute and tell the difference when we see neurilemoma and neurofibroma. So when it is neurilemoma, this is your axon and this is the Schwann sheath that is covering the entire axon. So if the tumor is of the Schwann cells, you see those cells present over there, and depending on the section, you see type A and type B. But when it is neurofibromas, you will see the nerve proliferation, the axon proliferation, the Schwann cell proliferation, as well as the endoneurium that proliferates. So this is the basic difference that you have, though both neurilemoma and neurofibromas are common, neurilemoma being more common than neurofibromas. But in both the cases, the lesions were present, like one was present in the palate and one was present in the parotid. So the first diagnosis was a salivary gland lesion or a salivary gland tumor, and it turned out to be neural tumors. Just sometimes the clinico-pathological correlation doesn't exactly give you what you would expect it under this microscope. The lesion was excised, and actually nowadays sometimes we do this for regenerative purposes. A buccal pad of fat was taken and was used as a graft material. The patient is hale and hearty. He's under the follow-up and he's okay. He has not developed any recurrence, any other lesion as of now. Coming to a fourth case, which is probably the most difficult case that we diagnosed, and we took a lot of help from the general pathologist as well as took a second opinion as well, was the case of this 50-year-old male patient. Actually, the patient had reported to us last year in January. We did a big follow-up in this case, but the first time when you see this patient and he comes and he says that he doesn't have any pain, but he wanted to get a filling done and he wanted to remove this crown. We thought probably the gingival growth is because of this crown and get a cleaning, that's all. So when he came to us, it just looked like general periodontitis. It looked a little suspicious as well because there was no interdental papilla here. So the patient had history of smoking. So we were not very sure what are we looking at, or when the periodontist also called us to see where should we take the biopsy from, or do you require a biopsy or just a generalized scaling would do. So we advised complete scaling and all, but the lesion didn't regress. Then we actually took biopsy from this side and this side. We had to give candid oral ointment also to the patient because there's candid involvement here, and just look at the periodontal. It looks like periodontitis, but in a second go, if you look carefully, it's not a typical case of generalized periodontitis. Sometimes in HIV also this kind of picture is seen, where you have this necrotic bone loss, and it doesn't always appear very black and all, but you do get these kind of picture where there is complete bone loss but no pocket as such. So we ruled out the HIV status of the patient, and we got some other blood biochemical findings which were surprising, which we will be discussing later. So the patient had serum acetylene converting enzyme level, SACE levels were high, and there was hypercalcemia also. So once we took the biopsy from these two cases, we received the biopsy, 2 bits of it, and then we looked it under the microscope, and this is what we got. the epithelium was present, and this whole area showed inflammatory component. So at first go, you look at it, you think it is a chronic inflammatory lesion. Anyway, the clinical appearance was similar to that. You had gingival proliferation, and then you had that periodontitis. But if you look very carefully, there are different areas in this. If it's easy to appreciate, can you see this area? Or can you see this area? So you see a lot of cells. This is also very, very cellular, but the cells are different. Here you have small lymphocytic or infiltrative or chronic inflammatory cells that are seen. You have some blood vessels, and you have these kind of lighter staining areas. Can you see this areas? So which we also missed in the first go, to be very honest. And then we looked at different sections of it. So it showed similar picture, like there's some areas which seem little fuzzy, and then the whole area showed inflammatory cells, primarily lymphocytes. So we thought it is a granuloma. So when we look at a granuloma, the first protocol is you need to see whether it's an immune granuloma or a foreign body granuloma, because in gingiva, foreign body granulomas are also some commonly seen. There is necrotizing and non-necrotizing, because there is no necrosis seen throughout the slide. We checked that. So in necrotizing, it is similar because there is a pattern. You have the necrosis, you have the epithelioid cells, and then you have the T lymphocytes that are seen. But in non-necrotizing, primarily sarcoidosis, you have epithelioid cells, and you have giant cells, and you have lymphocytes, but they are not arranged in the granuloma formation. They are not even as neatly arranged as it is seen in this picture. They're also known as decayed granulomas because you may not always get a peripheral rim of lymphocytes, but you always do, in cases of healing, get a lot of fibrin deposition. So it gives you that cigar bundle or that compact appearance. And you also see these asteroid bodies, and you see Squamous bodies or conchoidal bodies, which were not seen so much in our picture. So we thought it is sarcoidosis. So we took a second opinion, we showed it to a general pathologist as well. And then we realized that you can never make a diagnosis of sarcoidosis just based on the clinical or on the histopathological picture, because none of them are pathognomic. The histological picture which I get today, you may not have it. You may have a different kind, and the textbook picture is entirely different. So we realized that sarcoidosis or non-caseating granulomas, the diagnosis has to be made on exclusion. You have to exclude other things, and if none of this is fitting it, then you're probably looking at sarcoidosis. So we looked even more carefully after we were given a heads up that it could be sarcoidosis, and look, we got these areas just showing giant cells, epithelioid cells, or some clearer cell over here, then an epithelioid cell here, an epithelioid cell here. So in cases of sarcoidosis, the macrophages are not ingesting anything. So they are not like clear, or they are not very obvious because they've ingested something which is not stained by HNA. So you just see macrophages or epithelioid cells, and they are merged in the background, but they have a very prominent cytoplasm, and you see a lot of lymphocytes. So in cases of sarcoidosis, when you look at the pathogenesis, there is something like sarcoid antigen. Now the sarcoid antigen could be anything. It could be your Mycobacterium tuberculosis antigen, or it could be a fungal element, it could be a foreign body, it could be anything that triggers an immune response, which causes accumulation of these T cells. These T cells further secrete interferon gamma and other cytokines like tumor necrosis factor alpha. It also secretes interleukin 12 and 18, and all of this cause an accumulation or a granuloma formation. Further going, we saw some of these cells, which we were not sure whether we can call them asteroid bodies, which are characteristic features seen in sarcoidosis. Now, when I did a little more literature search on asteroid bodies, I realized that these asteroid bodies are formed because of three mechanisms. There is no clear-cut definition of why you will get asteroid bodies. So it could be that this is phagocytosed material. It could be that they are degrading collagen fibers within the macrophage, that you get these kind of star-shaped structure. You also get a lot of crystals which are part of dystrophic calcification or deposition of salts in that. Or third theory that they have proposed for asteroid formation is that the macrophage is turning into a fibroblast lineage. which was really surprising for me when I read it. And these papers are actually pretty old, 1977 and 80, and now after that, not much work has been done. Because clinical workup of sarcoidosis is very important to see whether you have any infiltration in lung, in skin, in liver, in other intestinal organs that you have. So we did a complete rule out of this patient along with the medical college, and luckily the patient didn't have any other symptom or any other area which had granuloma formation. They don't do Kevin test anymore. They just did some other genetic tests and they found that the patient didn't have. It's a solitary case of sarcoidosis that we saw. So to rule out, we did PAS staining, we did Gomorrhe's methylamine stain and Zeal stain to just rule out that this granuloma is not an initial formation of tuberculosis or now since it had come in the COVID period, any other fungal infection that it was or candida, anything, but it just came clear. There was no other thing. The patient was started on the therapy and she responded well. So this was the final picture that we got, and this is what you get in the textbook. So you can see over here nice granulomas that you get. So maybe this was a very initial stage, so we didn't have the setting of the fibrosis in it. Once the fibrosis or the healing phase starts in sarcoidosis, then the granulomas get dispersed and very delineated. But here it was just like a complete carpet of cells with few areas which were showing lighter areas which on higher magnification showed the presence of epithelioid cells and few giant cells. For diagnosis of sarcoidosis was given. So the main aim of showing this is to say that sometimes you would get a completely different picture. So just don't ignore it as chronic inflammatory lesion. You need to work out on the patient, because so many times when you ask the surgeon, how is the healing, post-operative healing? Based on that, sometimes we give the diagnosis that maybe it was just an inflammatory lesion because the lesion has healed completely well. It could always recur back. So the main thing is to go in a particular sequence, a very methodical or systematic sequence or protocol that you have established for your lab, and see that and take a second opinion, or if required, sometimes if it is. Case 5 is a simple case where we saw this one patient, 49-year-old male patient, history of tobacco chewing, areca nut chewing, since past 20-25 years, and the patient had overall leukoplakic and appearance of the inner mucosa, and it also had a non-healing ulcer here. And this was a lesion that the patient actually noticed. He didn't notice the non-healing ulcer because the tooth had removed and he didn't have any pain. So 2 biopsies were planned, one from here and one from the socket of lower 6. We got 2 tissues. And what we realized is in the socket from the 6th area was a highly dysplastic carcinoma in situ, probably early invasive form of squamous cell carcinoma. But the anterior lesion showed a different clinical picture. There was epithelial proliferation, but there were certain changes in the connective tissue papilla. Is it easy to decipher? There were certain changes. See, this looks very normal. You have inflammatory cells, collagen fiber bundles, fibroblasts, and there is no invasion seen. So we can say that anterior showed an invasion, posterior showed an invasion. But if you look properly in the connective tissue papillae, you had these granular large cells. They were limited only till this area. So these are basically macrophages which have ingested lipid-laden material. So they are also known as xanthoma cells. Nuclei and these cells, how it appears in the routine HME theme. Again, the etiology of verruciform xanthoma, the diagnosis was given as verruciform xanthoma, is not completely known, but it is hypothesized that the keratin becomes antigen. So the T lymphocytes basically recruit these macrophages to that site. So and also neutrophils. So the macrophages are recruited by this monocyte chemoattractant protein, MCP1, which has the CCR2 receptor. So that is why most of these macrophages are recruited only into the subepithelial connective tissue papilla layer. And when these macrophages are recruited, they ingest this. When the keratinocyte disintegrate, they ingest the lipid protein that is present in the cell membrane, and when stained with H&E appears like this. But if you look into the literature by Raval et al. Or by Zugergi et al., they have shown that most of these lesions are associated with some form of epithelial dysplasia or epithelial alteration. So you see a lot of verruciform xanthoma associated with lichen planus, associated with pemphigus, and now in our case, it was associated with an early invasive or carcinoma in situ diagnosis that was given. So this could be that the epithelial changes brings about this kind of change in the connective tissue with the attempt by the body to limit or circumscribe that the entire lesion so it doesn't progress. An interesting finding that we got in verruciform xanthoma, which was otherwise a very classical form of slide, was these kind of inclusions at the top of the epithelium. These are nothing but neutrophil abscesses, also known as Monroe's abscesses, but these are present only in the topmost layer of the epithelium. And then later on, digging on the literature also revealed that these T lymphocytes release interleukin 2, which is also responsible for neutrophil migration. So you get these neutrophil abscesses, epithelial abscesses in the verruciform xanthoma. It was an interesting case that had just come in our department. So final diagnosis of verruciform xanthoma was given. Coming to the sixth and the last case for today, we had a 12-year-old boy who had come, and basically these are the premolars, and the first molar was the primary molar was extracted. The primary E was extracted, was the first molar, and the premolars had come. So the patient had come reporting there was no pain. The patient was asymptomatic, and the parents had got him here because this is a small mass, and they were not sure if a tooth is erupting in this area. So we took an X-ray. There was no tooth, so probably he required a space maintainer. So what we did, or he had got his this looked like a second molar. So he's got his first molar extracted. So we just took this tissue, and it showed epithelium and connective tissue. So we thought, okay, this looks more like a fibroma kind of thing, where you see epithelial proliferation, you see a lot of collagen fiber proliferation, and you see this tiny bit of odontogenic cell, looking like odontogenic cells. We were still not very sure. Deeper section revealed kind of odontogenic rests. Odontogenic rests. Darkly staining nuclei, you see the cytoplasm which appears vacuolated or clear, probably because of glycogen deposition. Very commonly seen with cases of odontogenic epithelial. The section reveals areas of odontogenic epithelium. So now, considering the age of the patient and considering we had a missing tooth over there, we were not sure whether this is part of odontogenic rests over there. But then we also saw a few areas which showed calcification. And this is the epithelium in high power. You can see that epithelium which proliferates down. So many times we say for odontogenic cysts and fibromas, odontogenic cysts and tumors, that it derives from the basal layer of the overlying epithelium. It just looked like transforming into odontogenic epithelium, and there were odontogenic rests over here. And then areas of calcification. Easy, this was fibromatous component, peripheral, showed an overlying epithelium, showed a lot of odontogenic epithelial rests, and areas of calcification. So this was an epithelium-rich type of odontogenic fibroma. Another section. Small lesion looked like a soft tissue proliferation, but turned out to be odontogenic fibroma. We rechecked the history, and yes, the 6 was extracted long back, or it was carious and then it was extracted. So the 7 there, and odontogenic fibroma associated with an extracted 6. A final diagnosis of odontogenic fibroma, WHO type was given. So all of these cases clinically showed a different picture, but histologically was well within our purview of diagnosis. They were easy cases except for sarcoidosis, which we really needed to dig and ask for second opinions, do other stains to rule out. But otherwise, most of them were okay, and they can be seen, they can be diagnosed based on pure H&E. So the second part of my talk was just re-looking at the histopathological examination of oral squamous cell carcinoma tissue. So we had a lot of oral squamous cell carcinomas which were operated, and because of the COVID, they were in T4, T3, T4 stage as well. So where the tumor debulking was done. So in continuation was what Meenal ma'am was showing in the last picture, presentation, and in our last slide as well. There were a lot of factors which a surgeon requires when we are reporting it to be oral squamous cell carcinoma. The normal tendency is you see the slide, you see it is well, moderate, or poor, because it's much easier to diagnose squamous cell carcinoma. You label it and give it off. But there are a lot of factors which I think we need to look more in depth. So these were few cases of OSCC which actually perplexed us, which made us do studies on the various stromal components. So I would just like to share it with you. So we all talk about epithelial mesenchymal transition in oral squamous cell carcinoma, where the epithelium is evading the immune response by transforming into the mesenchymal component. So many of our tissues, now we saw these kind of cells. It is an epithelial cell, which is surrounded by a lot of fibroblastic component and all, which may be transforming into mesenchymal cells. We thought that sometimes EMT can be seen in squamous cell carcinoma, normal routine histological sections as well. It's another section which shows. So where there is a change in morphology of the epithelial cells and it is transforming or looking more like mesenchymal cells. We didn't do any IHC for this, but I thought that maybe we should start reporting where we see abnormality within the tissue, even if it is an incision tissue, which is not much sometimes. Another component is to look at the immune cells in the stroma. Like the first one we started was tissue-associated tumor eosinophils, because this is like the double-edged sword, like your steroid treatment, you know. It has tumor initiation and progression, and it has tumor regression properties. So luckily for us, a large survey that was done found that eosinophils have tumor regression properties in oral squamous cell carcinoma. So we looked at a lot of tissues and we did not find tissue eosinophilia in all of them, but in some cases, we did find more eosinophils in the background, more eosinophils in the stroma. This is the malignancy part. A lot of eosinophils were seen in the tumors. So now one of our students is doing this project to try and see how the eosinophilia, especially the tissue-associated eosinophilia or TATE that we call it, is responsible for maybe invasion or increased aggressiveness of the tumor, or a direct invasion or submandibular gland in the salivary glands or into the lymph nodes, neck node invasion and all. So what I want to say is, when we get a squamous cell carcinoma tissue and we diagnose it as say well differentiated or moderately differentiated squamous cell carcinoma, and we give the diagnosis to the surgeon, after that, I think we need to follow up that patient for a period of 2 years and 3 years and keep a total tab of what are the histopathological changes that we observe in the primary specimen. Like one was tissue eosinophilia. We can go ahead and do a comprehensive analysis of how many cases we saw tissue eosinophilia. What was the prognosis of the case? Did the case recur back? Was it already into T3, T4 stage? So that needs to be done. So here you can see the tumor invasive front, and we had eosinophils in this. The second thing that we had was we saw clear cells or glassy appearance in oral squamous cell carcinoma. There was a lot of debate that took place in our department whether this is squamous cell carcinoma or we're looking at adenoid variant, or have we discovered a clear cell variant. And this was just a part of the big squamous cell carcinoma picture that we had. It was a moderately differentiated squamous cell carcinoma. And look at the cells that we had. Gingivo-buccal complex, patient gives history of tobacco chewing, areca nut chewing, everything. And it was later diagnosed as adenocarcinoma or adenoid variant, not as a clear cell variant. But these were also the different features, and now we are keeping track of what happens to this patient who shows metaplastic changes. What happens when the tumor microenvironment is different than the routine one, or if the inflammatory cell composition is altered. So another study that we are proposing is, and it is being done by Dr. Vaibhav in our department, is this T cells and B cells in OS squamous cell carcinoma. So I heard a lecture like 10 years back which said that
Ma'am. The session seems to have been disconnected. Kindly bear with us. You can kindly post your questions to Dr. Supriya Keoth ma'am in the chat box, please. You can do the same in the live session on YouTube also. Ma'am is joining now. Kindly bear with us while we face this technical difficulty. You can post all your queries and questions to Dr. Supriya Keoth ma'am in the chat box, please. I take this time to announce that a CD feedback form will be given in the chat box later on in the session, on filling of which you will be given the e-certificate for this program.
I'm very sorry.
Welcome back, ma'am.
Sorry.
It's worth the wait, ma'am. Kindly share your screen now. Addressing to the suggestion by Dr. Revati Deshmukh, ma'am, we will be sharing the CD feedback forms via mail as well, ma'am, to all the registered delegates. We apologize for the technical difficulties we are facing. We have now sorted out all the difficulties and we are back to presentation by Dr. Supriya Kheur, ma'am. Ma'am, kindly take over. Thank you.
I'm very sorry with some issue. So what I was saying is we thought that this is epithelial mesenchymal transition. And we were looking at the role of immune cells in oral squamous cell carcinoma progression. So I spoke about eosinophils. Then another project was taken up in our department by Dr. Weber. So we were looking at this T cells and B cells subset in oral squamous cell carcinoma. Now, I very distinctly remember listening in DIFR 10 years back about the role of T cells and how they modulate the entire tumor environment. But there hasn't been any long-term studies which says that if I get this subset more, if I get these immune cells in squamous cell carcinoma, incisional biopsy more, the chances that it will recur, it will regress, or it will undergo secondary transformation, or there will be mortality is discussed. So we did an analysis of over 147 cases, wherein we stained it with CD3 IHC marker for T cells and CD20 for B cells. And the interesting finding that we found was, in most of them, the B cell proliferation was in form of smaller aggregates, whereas T cell proliferation were more in form of generalized presentation. And we checked out in some tumors, like in cases of breast cancer or in small cell lung cancer, what they do now, the T cells are responsible for recruitment of the B cells, and they make it more antigenic, that hotbed of antigenic susceptibility. So this would make the tumor more susceptible to immunotherapy or for treatment point of view. So I was saying that if all of us, like CD3 and CD20 are very pretty common ISC markers that are available in general pathology lab also, or in our labs also. So we could look it up into this, that we do an incisional and an excisional and try and evaluate or quantify the immune cells and see if it has any role in prognosis. The other thing that I think all of us should seriously look at are these tertiary lymphoid structures. See, this is a tertiary lymphoid structure that is seen in this specimen. And you see this germinal center like ring is also there. So these tertiary lymphoid structures are nothing but extranodal lymphoid aggregates. And if we happen to see them in oral squamous cell carcinoma, they actually indicate or flags that this tumor is more susceptible or is more prone or amenable to chemotherapy. Now, till now, we have been very classically told that oral squamous cell carcinoma means surgery. The chemotherapy is either an adjunct therapy, or it is done to just debulk the tumor, or it is done in cases of T3, T4. Their treatment is probably or surgical surgical removal is not possible in all the cases. There we do. But now, looking at the newer generation of immunotherapy drugs that have come up, or even my sir, Dr. Hazari sir, is actually looking at metronomics chemotherapy, wherein you are supplying lower doses of chemotherapy over a longer period of time to manage these kind of patients. So we need to look at these aspects also, or look into oral squamous cell carcinoma from this point of view also. So we did these germinal-like centers, and when they were shown to have CD20 positive cells or B cells which are associated. And I mentioned that if I see more of B cells, that means that tumor is more susceptible to immunotherapy, more modulating towards immunotherapy. So maybe all of us, like ma'am has already told, Minal ma'am was telling that we should have support systems. We should have different teams for looking into different aspects of oral squamous cell carcinoma, and we should all of us should sit together and collaborate. So I suggest that all of us get oral squamous cell carcinoma incisional and excisional tissue. We should start formulating a protocol for all the immune cells that we get over there, like T cells, B cells, eosinophils. What do we get? Any tertiary lymphoid structures in there? Do we get any other form of epithelial mesenchymal transition? We get muscle degeneration. So these the most common features that we look at are perineural involvement, lymphovascular involvement. So I think these all should also be included. Like we did a study which also got published into neutrophil elastase, and we found a very positive correlation between neutrophil elastase staining and squamous cell carcinoma invading into the lymph nodes. So there are a lot of schools of thought. Like if you go by the article that Dr. Anil De Cruz had put in the New England Journal of Medicine that says even NO stage, the neck has to be removed. It is agreed, but if we can predict what all are the factors within the primary tumors that could cause widespread lymph node involvement of the disease, we would still be one step better or one step ahead to tell the surgeon, look, this might go, so probably chemo should be started. Look, this tumor looks chemo resistant, so maybe chemo wouldn't do. You should go for radiotherapy. Or as in taken very active role in deciding the treatment protocol and deciding the prognosis and overall for long-term follow-up of these patients. So just to carry the message home, I think that OSCC report should have the following things checked. Whether you see any tertiary lymphoid structure, because that would make it more amenable to any form of chemo. What is the lymphocyte distribution? Do we see more T cells or we see more B cells? If we see more B cells, again, further as per the literature, the tumor is not chemo resistant. It is susceptible to chemotherapeutic treatment that can be given. What is the neutrophil and eosinophil distribution that we see? Higher number of neutrophils and eosinophils in oral cell carcinoma can have a protective effect. Though there are a lot of debate about the role of neutrophils and neutrophil elastase and eosinophils in various other tumors, but most of the studies have been done in germ cell tumors and breast cancers and all, where you very actively give chemo. But I think we should start looking at oral squamous cell carcinoma in a different form. And the most important is margin assessment. This is very, very important. Just seeing it as positive, negative, or you see this plastic epithelium in the margin or whatever, we need to sit back and make a small group that says margin assessment, because this is very, very important, which is the main reason why most of the tumors recur. So what I would want to say or conclude my whole talk as that we have two different group of tissues or group of structures that are generally seen in our practice. So as of now, just seeing the microscopic slide should not be enough. Seeing the patient is very important. Following up the patient is very important. So we have a lot of raw data, but we do not have structured data, which would get us good publications or which get us more peer support from all over the world. So we need to have a proper assessment of the squamous cell carcinoma tissue, and in which we would be able to mark the prognostic features, which would over a period of time do a lot of good to the patient as well as to our. Thank you. This is my team of the pathology and microbiology from DY Patho Dental College and Hospital. Thank you for patience.
Thank you, ma'am. Thank you for your wonderful, valuable talk and an excellent slide seminar in which we saw classical histopathological pictures, but the cases were disguised in their clinical presentations. Thank you, ma'am. Over to Dr. Sangeeta Patankar, ma'am.
Hello. Supriya, it was a very interesting and an informative seminar.
Your photomicrographs were a delight to the eyes, I must say. Yes. And
Ma'am, we can hear you. You may proceed.
can you hear?
Yes, ma'am, loud and clear. Please go ahead.
So I must say, Supriya, your photomicrographs in your slide seminar were a delight to the eyes. I think everybody agrees to that. If somebody has such good photomicrographic representations in one's publication, I'm sure you will not have any problem with any international publication. Yes, and Supriya has shown that you should not settle for anything which is mediocre. It was the best presentation I have really seen so far. Yeah, and you have really done a very meticulous workup of each case. And so this is how it should be, a clinico-pathological correlation. And I'm sure you are a true inspiration to all the young and budding oral pathologists all over India, I must say. So thank you.
I'm your student only.
Yes, and since she is mentioning that, I will say here that I had seen spark in her right in third year when she was in my batch. So I knew that she's going to be really good in whichever field she chooses. So it was really good to have you with us. And thank you for sharing information about all your slides to all the pathologists. Yeah, thank you.
I thank Dr. Patankar ma'am for her kind words. We now move on to the question answer session. It looks like we have a few questions for Dr. Supriya Keown ma'am. Ma'am, kindly answer the same. It would be of great help to all the delegates. The first question is from Dr. Rahul. Sir asks, ma'am, the sarcoidosis case, how can we distinguish that with Regener's granulomatosis or orofacial granulomatosis?
It is difficult to diagnose. Sarcoidosis is mostly based on exclusion only. So Wegener's granulomatosis and or orofacial granulomatosis will show you proper granuloma formation. Over here now we did see some asteroid bodies, and we did this Gomoris, methylamine, silver, and Zeal and sustain to rule out the tuberculous or caseating form of granulomas as well as the fungal granulomas. So Wegener's granuloma, also the location. Most for orofacial or Wegener's granulomatosis, the location is generally in the midline, more commonly in the palate, as compared to this case that we had. Though sarcoidosis, you can see the presentation in the palate, in the buccal mucosa. Gingiva is actually a very rare form of sarcoidosis that is seen now. Up till now, only 70 cases have been reported there. So it is difficult. It is more on exclusion. Plus, our patient serum angiotensin converting enzyme SACE levels and hypercalcemia was present, which would not be there in cases of orofacial granulomatosis and Wegener's granulomatosis. This answer.
Thank you for answering the question, ma'am. The next question is, in the first case, the treatment protocol for amyloblastic fibroadenoma will be same or different?
If it is amyloblastic fibroadenoma, you would have gone for a little conservative treatment. So they excised from the first molar, from the second molar, primary second molar till the first molar. So maybe we would have just excised this area, allowed it to heal and see if it recurs. But since the incisional biopsy was given by the general pathologist as ameloblastoma, now that treatment protocol is 1 mm of normal bone margin should be present. So they went for aggressively, but PMMC flap was done for rehabilitation. But it is a growing mandible. So had it been amyloblastic fibroma or fibroadenoma, we would have gone for little more conservative. Though this front portion would have been lost any which ways, which we discussed later with the surgeons also. But maybe a little less bone could have been saved.
I'm keeping in line with the first case. How to differentiate between amyloblastic fibroadenoma, amyloblastic fibroma, and odontomas histopathologically?
No, so amyloblastic fibroadenoma would give you also the presence of enamel matrix-like areas or areas which are devoid, which probably enamel matrix was present, and cementum. And odontome would obviously give you all the three structures either haphazardly arranged or arranged together. So in this case, we did not get any enamel-like structure or any cementum-like structure. We just got hyalinization subepithelially present, which are typical features of ameloplastic fibroma. And we found areas which were showing dentinal tubule formation. So then we diagnosed it as that ameloplastic fibrodentinoma.
I'm keeping in line with the same case. To elaborate on the continuous different stages of development of a single entity in mixed odontogenic tumors and the name of the author who gave the same.
It was given by Kahn and Blum. Okay, so that is a continuum theory, but this is no longer advocated now, or it is not accepted anymore now, because there have been changes in gender in the area that this lesions are seen, as well as the clinical presentation. But it was taught to us in third year also, and this concept is still there of this continuum theory, wherein you have ameloplastic fibroma, dentinoma, fibrodentinoma, fibrodentinoma, and an odontoma, but it is no longer advocated. We have not been able to get a complete concrete proof of it.
Thank you for answering the question, ma'am. It will really help in the historical aspect for the postgraduate students. Continuing with the question session, ma'am. The next question is from Dr. Pradipta Patil, our very own PG student, passed out now. Her query is regarding the nerve sheath lesions discussed, how to differentiate between the two histopathologically.
So ideally, in a histopathological situation in neurolemoma, you would see the Verroque bodies, correct? You will see the palisaded appearance of the nuclei and the areas which appears nuclear or appears plain eosinophilic, where the cytoplasm is. So whereas in cases of neurofibroma, where there is a proliferation of axon, the proliferation of fibroblasts, the proliferation of endoneurium, there are myxoid areas. So you will see the nuclei, the nerve nuclei separately, which is that bent dolphin or slightly curved, or which shows serpentine appearance. So the areas are entirely different. Now, in cases of neurolemoma, you have anterior type A and type B. Though in our case also, we did not see too much of anterior type B, but we had anterior type A, which was very classical diagnostic as feature for neurolemoma. Whereas in neurofibroma, we had mixed appearance of nerve cells, fibroblasts, and few areas of myxoid areas. Plus, if you do S100 staining, which is also commonly available in ISC, in neurolemoma, you will see a lot of staining of S100, which will be more sporadic and discontinuous in cases of neurofibroma, because one is completely Schwann cell tumor and the other is a mixed tumor. Both of them are encapsulated, both of them can appear solitary.
Thank you for the explanation.
Again, you can also look at glial fibular acidic GFAP for ISC staining if there is a confusion, because there's something known as cellular schwannomas, which may not show Verroque bodies. But neurofibroma typically will show you fibroblasts, neural elements, Schwann cells, and will show you sporadic staining of S100 ions.
Moving on to the fifth case discussed, a question regarding the fifth case. In the verruciform xanthoma case, were any cholesterol crystals or giant cells visible? How common are they?
No, they were not visible. And here also now most of the defense mechanism or most of the recruitment of the macrophages is only into the connective tissue papillae that are present. Correct. So it is not basically an inflammatory lesion, though the etiology is really not known. But what they are seeing that something becomes antigenic and there is an immune response to it in the form of these T cells recruiting the macrophages in that area, which ingest the degraded or disseminated epithelial cells, especially the lipid part of it, which is the part of the cell membrane, and gives you these xanthoma cell or foamy cell appearance. There were no cholesterol crystals. Thus, the deeper areas appear pretty normal.
Thank you for answering the same. It was a delight to listen to you, and I'm sure the postgraduate students must have been introduced to many different words today, right from diving dolphin, carrot collagen to asteroid bodies. We have one more question, ma'am, about spectrum of odontomas. If you could elaborate on the same.
So, if I get you correct, you need to say the classification, like you have complex and compound odontomes, and you also have a hybrid odontomes. You have complex composite odontomes. So the odontome is basically an attempt or an not a very good attempt at formation of tooth structure, correct? So you would have enamel dentine and the cementum as well as the soft tissue component and haphazard arrangement over there in an attempt to make the tooth. So if you can make a tooth that becomes a supernumerary tooth or an actual tooth, whereas the rest of it is just a part of the tooth to have the deposition of all the three elements. So depending on how the relationship of that with each other is, we have it in a very primitive stage of an odontome and as good as a supernumerary teeth or a complete full formed or a compound odontome. Or you could have an hybrid odontome.
Thank you, ma'am. I think we have cleared all the questions and thank you for answering the same, ma'am. We now move on to the felicitation ceremony. We thank both our esteemed guest speakers today, Dr. Meenal Chaudhary ma'am and Dr. Supriya Keoth ma'am. Kindly accept a token of appreciation from our side to Dr. Meenal Chaudhary ma'am.
Thank you. Thank you so much.
Thank you.
And I'm sure all the delegates have been introduced to an innovative approach looking towards OSCC today, not only in the post-operative care, but also a new look in the histopathological examination of oral squamous cell carcinomas. Thank you, ma'am. Thank you for the same. We now felicitate Dr. Supriya Keoth ma'am, our second guest speaker for today, for giving an excellent slide seminar followed by a additional presentation for the benefit of all the delegates today. Slide seminar on histopathological insights into oral lesions. Thank you, ma'am. Thank you once again. With this, we have come to the end of our program today. I would like to thank, sorry, ma'am.
Please,
yes,
please also give thanks to Dr. Shenma, please.
Yes, ma'am. Sure, ma'am. I'm about to. Thank you. I would like to thank everyone who made this program possible. A special mention to our guest speakers and delegates from all over India. We are delighted to announce that this program has been approved by our Maharashtra State Dental Council. And we thank our observer, Dr. Shailesh Shenwas sir, for joining for the complete session. And a special thank you to you, sir. Delighted to have you. We are delighted to have you. We are delighted to announce that this session is, has been approved by Maharashtra State Dental Council for a total of 4 credit points. So I'm sure all the delegates will take good use of the certificate as well. Thank you to all once again. If I could request all the delegates for just a few seconds to put on their videos on, we would take a common group photograph and that will help in the documentation purpose. Kindly switch on the video call. I request the delegates to kindly switch on their video for a few seconds, take a common group photograph. So good to see and meet all of you virtually. Hoping to see you all in person soon at some CD event organized by our college, or we would really love to travel and come to your colleges as well. Thank you all for a wonderful, for being a very delightful audience. Thank you, everyone. It was a pleasure being with you today. Have a great day and hope to see you all again next time soon. Thank you.